I'm proud to bring to the podium for a talk on ultrasound, the Dupuytren diagnosis and treatment, Esther Vögelin.
Thank you very much. So why should we use ultrasound when Gary Pess can do it over 40 years blindly and just by palpating? Maybe because we don't have this experience. So you can use ultrasound in Dupuytren's disease to diagnose Dupuytren's or even for treatment, as we will hear later on. First of all, there's a nice study of workers group where they showed that proliferative and involutional phases in Dupuytren's have a different aspect in ultrasound. Because of the high density of myofibroblasts, it's hyperechogenic, as you see or may see here. This is a typical hypoechogenic space of Dupuytren's disease, or here in this area you see, or you may see it as well. Whereas during the residual phase, you have the acellular cords, and this Dupuytren's tissue is hyperechogenic. You see the fibers, or you may gather the fibers. This may also have prognostic value, and that's why I think it's fascinating to use ultrasound also diagnostically. When you use it therapeutically, you have two methods in the sense of infiltrating the nodules or the cords, and later on we will even hear how to use surgery using this technique. In-plane method is when you see you keep your probe over your cord and you follow the needle in the tissue, and you see exactly where you place your drug, your local anesthesia, or your other medication. Out-of-plane method is when you use the probe transversely, and this is in the beginning certainly more difficult because then you have to look for just a small hyperechogenic point where you put your drug or your anesthesia in the tissue, as you may see here. Now, why should you use this sonographically assisted infiltration? This is a young man who has a abductor digiti minimi cord, as you see here clinically, and this is the cord in sonography. And when you follow the cord in the transverse plane, you may see, this is the flexor tendon, here you see the nerve and the vessel, and you can see that this cord is changing from palmar to the dorsal side. So when you want to really get rid of this cord by using, for example, Xiaflex or Xiapex, then the ultrasound gives you exactly where the cord is palmarly of the vessels and the nerves and where it is dorsally. Here you see how we inject that under guidance of ultrasonography, and again you see here the tendon, the bone, and here the artery, the nerve, and here is the cord palmarly. And this is the result, as you may gather, after the injection. Now, another example of a huge node and a Y cord of this ring finger that has been treated using this technique. And when you start with local infiltration of local anesthesia, you can see where your local anesthesia places, because you see it as a hyperechogenic fluid. Here you see that we have actually fluenced the cord in the transverse plane, and all the hyperechogenic dots are representing the local anesthesia here longitudinally around the cord, and then you know exactly where to place your medication. This is after the tearing the cord. So what would you do when you have a recurrence after having performed surgery? This is the case of a lady who actually made a diary because after surgery, even in the first month, she showed herself how the contracture of the small finger started again. This was after the second month, and after 8 months, she had again a contracture of 90 degrees. So who in the auditorium would do surgery again? Just 1, 2, and the rest, who would do what?
Maybe a dermofasciectomy.
You would do that, okay. I tried to use sonographically controlled collagenase because I didn't want to do the same again, probably also because we didn't know in which phase this recurrence reoccurred. And 12 months after surgery, she is still without recurrence after this treatment after surgery. So when using Xiaflex, you all know it's not anymore available in Europe, and we use it in Switzerland only as an off-label use. I use it after failed surgery because I am happy to do it sonographically assisted, even in the PIP area or the proximal phalanx. And of course, it's easy to say in the proliferative phase of Dupuytren's recurrence, but when you do a lot of sonography of these tissue, you seem to get an idea what is proliferative and what is residual. When you have a diffuse spreading of Dupuytren's contracture within the skin, I'm not a friend of doing a huge dermatofasciectomy. For me, it's a bit like we heard this morning, surgery is failing, and I rather would wait until we get another enzyme to use that to treat the Dupuytren's disease like that, or in combination with surgery. And also I use it in high-demand patients, musicians, professional sportsmen, and so on. I use Xiaflex right now alone when there is no residual tissue in due course. When you have developing, or you see developing, or you have left residual tissue, I combine it with surgery. This is, again, a piano player, and you see this is for me a very diffuse spreading into the skin. She had recurrent injection of Xiaflex, you see on the top 3 times already, first after 4 years and then after 2 years. And she didn't want to have surgery, but she couldn't get the octave, to reach the octave anymore, so we had to do something about it. So we did Xiaflex, but it wasn't enough. And then 14 months after Xiaflex, we did mini aponeurectomies. And then 9 months after surgery, she had this result and could reach the octave again and was very happy. I would like to show you, I did this kind of combination of treatment in 21 right hands and 18 left hands. I did 39 infiltrations. Of these 39 infiltrations, 22 were just infiltrations, and in you see here the amount of infiltrations, and in 17 times I combined it with surgery in due course. The delay between infiltration and surgery was between around 71 days, from 13 to 221 days. And when we had residual tissues, this was in 7 right hands and in 7 left hands, and you see again the delay between the infiltrations within these hands were in the right hand 27 months, in the left hand it was a bit more, 41 months. So what says the recent literature? We have actually heard that many times today, that recurrence is more common after collagenase compared to fasciectomy, and collagenase has the disadvantage that there is a lower deformity correction and resolution and an increased recurrence rate. This is shown in a 10 years review last year, and you see here the numbers between collagenase and fasciectomy. Another systematic review, these are just retrospective studies, again said there is a higher recurrence risk with collagenase compared to limited fasciectomy, and the limited fasciectomy has a more reliable, long-lasting result at the costs, however, of increased surgical morbidity. And everybody says treatment decisions should be made on a case-by-case basis. I'm still, despite these results, I think there are indications where where we and the patient prefer a less invasive treatment. There are many advantages, as we heard from Gary Pess as well. There is a lower morbidity, there is an earlier functionality, and there is less scarring. There is, in my opinion, significant less complicated wound healing. There is a softer scar condition after this treatment, and there is less intensive aftercare, and the subjective satisfaction is great. The SANE score is wonderful compared to limited fasciectomy, at least in the early phase. And with the residual tissue, I combine that with mini aponeurectomies, and I'm surprised how well this heals after having before treated with collagenase, and I also have to do less invasive surgery, and that's why I think it's in certain patients right now a very good alternative. And I hope we get a medication that we can combine that on a regular basis. Thank you very much.
Fantastic results. I mean, that's absolutely amazing. One question I have you ever tried injecting collagenase into the web spaces, releasing the natatory cords? Because sometimes those musicians can't get the web open.
Yes, when you take the small probe, it's possible to do it under vision, and I'm not so brave as you are. I need to see what I'm doing. Yes?
In cases which have been irradiated or have been operated, coming to radiotherapy, there are often questions to give a third series. And I made in Miami 2010 the contact with Aaron Wolfson, radiographer, and he has developed an MRI technique with contrast media, and I haven't discovered any paper on MRI technique for digital networks in this conference. However, we are using it to detecting the old fibrotic tissues, which can be detected and differentiated from the new proliferation, which is intensifying, has inflammatory components, but so we can direct our treatment much better on these new areas. And I think in comparison with ultrasound, it would be a very favorable way of combining these and addressing the actual inflamed cells. Because that's the target, and they would be also the target for radiotherapy, because an active proliferation is also better responding to radiotherapy than an overreaching.
Yes, I agree. Unfortunately, the beamer didn't show the ultrasound's very nice, but it's actually with a 24 megahertz probe, you don't need an MRI anymore. You see really, you see the differences of the proliferating or the involuting stages. And you see exactly where it is because you are the treating physician compared to the MRI, where you then get, of course, you get your sections, but it's not the same as with the ultrasound.
The nice thing for you as operator, you see what you actually.
Yes, exactly.
You prove others where the perfusion actually happens. That's a radiography, and you have a radiography on your practice.
Mm-hmm.
You do it, and then you treat. So it has each advantage, whatever position you take, but then you combine it also solve the problem.
Any other questions? Fantastic talk. Thank you so much.